Why does function data matter?
That's a great question. As you probably know, our healthcare system, like many others throughout the world, is focused on diagnosis. I recently did a TEDx talk and I talked about how we need to shift the focus away from diagnosis toward functioning and collecting information around functional status. Why this is important is because diagnostic codes are so limiting. There is no way to be able to provide the information that a healthcare provider, an allied health provider, a clinical provider needs to actually create an effective and sustainable intervention or treatment plan for that patient or client. We have to look at a comprehensive outlook of the person, which requires information around functioning. And that's the only way that we're going to be able to shift the focus to truly be able to make a difference in the lives of these patients, and not just about improving someone's functioning and health, but also improving their satisfaction, improving their happiness, their quality of life, and a term that we're hearing a lot more in flourishing.
And how is ICF different from ICD in that way?
Great follow-up question. ICD is the diagnostic classification system. It was created and it is maintained by the World Health Organization. I'm very fortunate to be part of this process of maintaining and updating the ICD codes. But as I mentioned, it just contains a unique code assigned to every health or mental health, behavioral health condition, an injury, illness, disorder, and so forth. Christina, if you and I had the same health condition, you and I would have the same code in the ICD system. But we know you and I are different people. We might have some overlaps. We're social workers, for example, but we know that doesn't tell us hardly anything about our lives and certainly not about our health and functioning. The ICF system was specifically developed to provide information about everything else. So you can imagine that's a lot of information. So information about someone's body functions and structures, about their activities and participation. So what they're actually doing in their lives, and participation being kind of the broader areas. Are they engaged in recreation? Are they able to be employed, which requires a lot of different functionings, right? Are they able to go to school? And what we also did when we developed in the late 1990s is we created a section on environment. Many of us sitting in that room, and I was a PhD student at the time in social work, we couldn't imagine creating something around functioning without looking at the environment. This is one of the key premises of social work, is that we look at person in environment approach, right? And so we were able to develop these categories and codes around a full range of aspects related to environment, which I might add predates social determinants of health. So I think from that point, we started hearing, about a decade later, and we started hearing the term social determinants of health, where we also hear now structural determinants of health and social drivers of health. But essentially, we're using them interchangeably, although they're nuanced a little bit differently. But very important that we actually bring that in, because we know that sometimes someone's quote unquote, let's say, disability or issue with functioning has more to do with social determinants of health, what is going on in their environmental context, than what is actually happening in terms of their person, right? So I think, just to quickly answer your question, those are the main distinctions between the ICD and the ICF system, and why I definitely emphasize using a functioning based system, specifically the ICF, which I am lucky to be part of over the last few decades.
Wow, that's amazing. How has it changed over the last few decades, and how have you come to think about it differently over the course of that time?
Well, one of the concessions we made when we built the ICF classification is the fact that we knew personal factors is also an important element. Someone's race, ethnicity, where they might live or be situated geographically, and so forth. However, it was a lot just to build a new classification in and of itself, but certainly a whole section on environment. So we made the concession to not similarly build categories and codes around personal factors. Part of that reason is just the variability and the diversity related to that was overwhelming. So one of the things that we've been hearing since we've been able to implement the ICF, and we do not use it here in the United States to like on a national scale. We were embracing the framework and the terminology, the classification, the instruments based on it are being used here and there, different systems, hospital, healthcare systems, and non-healthcare systems as well. But it is being used outside of the US in many different countries, especially those that are smaller in scale in terms of their healthcare and social care systems. What we we have been hearing that we really need to have the codes related to personal factors pulled into the classification. So that's one of the things that when we update the ICF, which we are planning to do, that we will be looking at that particular aspect.
Tell me more about how, if at any kind of iteration, do we use it in the United States? Because I know that there, just from personal, 10 years of being on the front lines in healthcare, functionality is a really big indicator on how this country parses out welfare. And I'm using welfare in that big general sense in terms of like long-term care, in terms of psychiatric, behavioral health, living situations, and in a lot of different things, disability, of course. And is that related to how the rest of the world defines ICF codes, or is that just something entirely different? Or do we measure it to a different, scope or extent?
Well, we are definitely using it in some similar ways and some different ways. And different countries will utilize it, in terms of like, here's the classification, and they just take it face value. Others and they use, for example, the definitions to be able to provide a basis for disability assessment in their country, or eligibility schemes. Then we have the codes themselves integrated into the healthcare system, and they're used for reimbursement and third-party payments and so forth. So we are seeing it kind of across the board. The United States, as I mentioned, we are such a global, massive healthcare system. We have not yet formalized how we might use it, but we are seeing it pulled in. For example, like the ICF is an official terminology with the VA, and the VA is one of the largest healthcare providers, as we know, in the United States, and employs a lot of social workers as well as other clinical providers. So they have a terminology, and they've been using it in different types of maybe acute care settings within the VA. Again, not systematically across the board, but different individual clinicians have caught on to the ICF and thought, this just makes a lot of sense. One of the ways that we're seeing it, and I do a lot of training, so people come up to me and go, I use the ICF and this is how I use it. One of the ways that I'm seeing is that because the ICF is a classification, it's not an assessment instrument, that people who do a lot of functioning-based assessments, as you already mentioned, a lot of clinical providers do this across disciplines, they take their own assessment instrument. And then what they have done is a process called mapping or crosswalking it to the ICF. And so they're able to discern. And right now we're seeing it clinically, but we see it published in the academic literature, that we're able to see that the ICF system makes a lot of sense. And part of the justification urging that we actually move to an ICF-based system. The reason why we don't necessarily see it, let's say, embedded actually into like billable system is because it hasn't been formally adopted in the US. But I think it's coming. It just makes sense because, as you mentioned, we are using functional-based assessments so much, but we're just not using it tied to the ICF, which could be, just an extra step. But with technology, we can streamline the process for sure. And we're not using it probably because we're still siloed in so many different areas. But as we move to a continuum of care, to me, that's where we're going. That's where we need to go to transform healthcare, is that we need to stop seeing it as here's healthcare, here's social care, here's the economic care aspect of people's lives and so forth. And we need to pull it all together. And we're seeing other people in academia, other scholars doing this, overlapping, let's say, health and economics, for example. And we've done it a lot in social work in terms of health and social care through the coalition, right, for social work and health. We need to come together and understand that it is like full circle, that these things all play with one another. One thing might precede another, but they all matter. And until we see it as a continuum system, we're not going to be able to make a difference in the lives of people. So when this happens, I think the ICF is going to be even more important because it looks at functioning across all those broad life areas, and we'll be able to assess, and we'll be able to maintain, we'll be able to monitor, and certainly we'll be able to determine outcomes as a result. We have, you mentioned SNF. And so we have buy-in with entities like like CMS, for example, right? Centers for Medicare and Medicaid, probably the largest employer of social workers. And so many people, on Medicare, and of course, by extension, Medicaid, as we already mentioned, Medicaid earlier, they are very interested in functioning-based care. And so the ICF is already being considered as the terminology to be able to code this. And we have been very successful through groups like the PASIO Project, which stands for Post-Acute Care Interoperability Resources. We're able to, not resources, but post-acute interoperability care. We're able to pull in, and we've been able to map various aspects of functioning that are relevant, certainly when we look at Medicare patients in Medicare settings, and code it to the ICF. So we know it is possible. And what I think is one of the major drivers, and what will be probably the major driver for the idea of continuum of care, as I previously mentioned, is health interoperability. The fact that we need to now pull in into electronic health records and have a system that enables us to make it portable, right? To allow us from setting to setting, from discharge, let's say from a hospital into a post-acute care setting, and then hopefully to home, that we're able to see those records transmit, that information transmit. And with that, we must have functioning information. It has to be in there. It just makes sense. And then if we're going to have functioning information, my recommendation, which is already being approved by these various entities in these work groups, is to use the ICF for that purpose.
How do you see that aligning with where the industry is headed in terms of value-based payment contracts?
Okay. So, as you know, right? I mean, the nice thing about, I think, with value based care and the idea that we're going to pay out for certain things of value is the fact that we are recognizing those other factors that impact health outcomes, right? So, the idea of social determinants of health, for example, we've already seen, like in hospital systems, performance indicators moving to things like patient satisfaction, right? That is relevant. And the reason why that's important is because it reflects more than just whether you get the proper treatment or not, whether that treatment is working or not. It's extending beyond that to the things that, and we called it patient satisfaction because we weren't actually able to tap into probably what it truly is, but it's all those other things. It's those other touch points, which I think are reflective in the fact of what people value, what people care about. And I think it's essential that we do this. I think that we pull these things in. And if we do it, and I know I'm speaking to the choir here with you, is that it will make a difference. And it might cost a little bit money up front in the beginning, but in terms of the dividends that will be paid out, certainly in the shorter term, but even certainly in the longer term, I think it's definitely worth it. And we just need to be able to capture this and be able to monitor it and then bring it back in terms of the evidence that is needed for a hospital or a healthcare system to be able to do. It's so important. I think about I love to do examples right in my classroom. I have a daughter who unfortunately got hit by a car in December 2023. And so she was rushed to our local hospital here in St. Louis. She was unconscious. And, when she finally woke up and she had multiple fractures and they had, of course, triaged her and immobilized her, because they thought that she might have a neck injury. She did experience a traumatic brain injury, but a lot of different things going on. And she was in the hospital bed for days. And and they, at some point, as when you're going to get discharged, you have to get you ready. You have to do certain things, right? You have to be able to stand and get up and walk and go to the bathroom. And she just was not motivated. One, she had, come out of just regained her consciousness a few days before that. She was on a lot of pain medication. But they were really trying to work with her, the physical therapist in the hospital setting, the nurses, to get her to move toward meeting some of those goals so that she could be discharged. And so then we stopped after a few days. And we finally said of this kind of lack of motivation and non-compliance, which you get a lot of those kind of terms in the hospital or any kind of healthcare setting. This is a non-compliant patient. And I said to her, we asked her like, hey, what do you want to do? What would make you happy? And so one of the things, and she was a teenager, she kept feeling her hair. Well, she had been, knocked across the road. So she still had debris and blood and everything in her hair, and she wanted to have her hair washed. And the nurse had told her, well, up on the 12th floor, we actually have a salon chair. So if you can get out of bed and walk and get there, we can wash your hair. Well, guess what? Within a few hours, with the physical therapist behind her, she was able to do that. So that was the motivation. By asking her what she wanted, we were able to achieve the outcomes needed, right? The information that was needed to say, yes, she's able to stand up. Yes, she is able to walk so many feet without assistance, and so forth and so forth. And so I think we need to change the way we approach healthcare from this very kind of tunnel vision idea of this is how we should do this is how we should do that, to start asking patients and asking family members on what they want, what they value, and then seeing, because often this is the case, and social workers know this, we can see the products and the outcomes as a result that we need in the healthcare system.
How is she doing today?
Thank goodness she's doing great. As someone who has been a disability scholar for decades and a person with a disability that, I have a heart condition, it's a different story, right? There's so much diversity within this area of disability, and I am learning a lot around traumatic brain injury for sure, and just so blessed to have some of the best care in the St. Louis area with her neurologist and so forth, to be able to take care of her. But she's doing great now. Thank you so much.
To hear it. What about social prescribing? Can you tell us what that is?
Yeah, so I got to know about prescribing a few years ago, and it's just really kind of interesting when we think. I just read something today on LinkedIn coming out of WHO about words matter, right? So the idea that you could create a prescription for the non-medical needs, just like you would have a prescription for a drug, like a pharmaceutical prescription, right? This is for a healthcare or medical professional to create a prescription for those other things that are needed, like what we consider social determinants of health. So this is already happening in the UK. There's a huge backing for this, but it is happening in other countries around the world, and it's actually happening in the United States as well. I've been lucky to work with a couple of people who are part of the Global Social Prescribing Alliance to try to bring this in a more systematic way into the United States. Where I see social workers to be involved is in two places. Well, one, they talk about if, let's say, a doctor were to create the social prescription because they recognize that there is a social need, right? Let's say food insecurity. There's a lot of people who might show up, right, at a hospital or an urgent care setting, an ER setting, complaining of a lot of gastrointestinal upset or stomach pain and discomfort. But what we really find out is there's an issue with food insecurity, right? It isn't something that is medically related per se. And so that would be an idea of a social prescription that we would refer that patient out to be able to address that food insecurity area. And so then the prescription goes to a link worker, is what the term is, and that person connects the patient or client to the resources in the community that is needed to address that social need. Social workers are one of those identified categories of link workers that be part of it. But I also want to elevate the social work profession because I don't think, and this is where I might agree with some of my colleagues in the social prescribing world, is that I don't think it necessarily needs to be a medical provider that does the prescribing. I think a social worker should do the prescribing. I think social workers are perfectly capable. We have competency based training, and we are already working in this area of social determinants of health. We've been doing it since our founding with Jane Addams and Whole House in Chicago. So we understand it because we go in the community, we meet people where they are, and we understand the full situation, right? And so I think social workers should be the profession that handles social prescribing, looking at the needs comprehensively and being able, which is what we're already doing, or working with, for example, community health workers to link those individuals with the necessary resources in the community. So that's the one thing that I would change in terms of what you would see as a traditional social prescribing model. But we know that when we're looking at the evidence, when you invest in social prescription, you're saving a lot of money, and the numbers vary. But like for every, I think, $1 that you invest in social prescribing, you're getting at least 15, if not more, dollars back on return. So hospital systems can save a lot of money. They've been doing a lot of evidence-based data collection and analysis in terms of these kind of financial figures. So we're seeing it be very well supported. Like in Ireland, there's a huge project going on. And it's extending beyond just your like healthcare system. I mean, they have a program on social prescribing in a football club, so like, which is soccer, I think, here in the United States, but it's becoming very popular to understand. And that goes back to what your first question was around functioning. That how do we make sure that we can enhance the functioning of people and their well-being and human flourishing, well, social prescription is one of the tools that we're going to be able to use because that is made specifically to identify the social needs or social determinants of health needs of individuals.
You said it twice now, so now I have to ask, what does human flourishing mean?
We're here. That is definitely a buzzword right now. We're hearing it a lot. I mean, actually, human flourishing, it goes back to the time of Aristotle, to be honest. But I forgot who the person more recently in the last 20 years has kind of coined it. But the idea that people can flourish, right? And that should be an end goal of their lives, right? It shouldn't just, it's, more than just well-being, right? It's more than just satisfaction. And there's different tenets of human flourishing, different pillars, different models that are used. One component is physical and mental health, right? So the idea that to have human flourishing, you must have good physical and mental health. And when I say good, it doesn't mean that, you're in perfect physical or mental health. It's just that it's good for you, right? And that's what I think is important, right? Not only do you have to have that, but you have to have things like happiness, for example. And that's a key element. You have to have some sort of purpose in life. So adds like values as well. And so this kind of gets into, I think, also what we had mentioned to your question about it isn't just about looking at someone in terms of getting the proper treatment to improve their health or their physical or mental health, but also looking at those other non-medical factors that might lead to higher satisfaction, right, in someone's life. And so that's what I think human flourishing really touches on. One of the things, though, that I differ probably from what we're hearing, in terms of the term, is that I look at it from the approach of capabilities. And this is some of my work that I've done from my dissertation back in 2005. The idea of Amartya Sen, who was a non-traditional economist who said, I want to look at other indicators besides looking at income, looking at wealth, for example, that are going to drive quality and a quality of life and well-being in people. And so he coined the term capabilities, the idea of taking functionings, right? What people are actually doing, right? But also understanding that they have to have agency. They have to have choice. They have to have opportunity. They have to have freedom. And that's a big component, I think, of flourishing, is that it isn't enough just to say, you've accumulated wealth, because even if you have that doesn't mean you're going to get access, doesn't mean you're going to be able to use that and convert that into functioning or enhancing your functioning in life. So we really need to look at what are some of those other things that are part of that process. And that was one of the things that I was able to contribute through my dissertation, is that to me is where the focus should be. Whether it's healthcare or whether it's a non-healthcare setting, we need to focus on how we're able to convert those assets into functionings or enhanced functionings for people, and figuring out whatever might interfere with that process in terms of barrier. And often it might be stigma, it might be bias, it might be policies, right? We need to be able to break those barriers down. And then that's when we're going to be able to tap in and be able to accomplish improved human flourishing.
Is there any capability, any functioning that is maybe underrated, that maybe people don't really take account of when they're assessing somebody's functioning in the community?
One of the things that I might say is the function is about agency. It's about an individual's ability to take command over their own life and destiny. And I think as social workers, we know that it's so important to have empowerment, right? To empower our clients when we work with them. And I think that is definitely, to your question, is that it's undervalued. It's undervalued by a lot of people. One of the things that I mentioned in my TED Talk is that I think we need to stop telling people what they can't do and start understanding what people can do. And I think that is the key. And sometimes if it means that that person might not do something the way that we would do it, or might even fail, let's say, right? It's okay. That if it's their choice and they're making that choice in their own lives, that we should allow them that and in a very dignified way to be able to do that. So that's what I would say. I think that's probably one of the more undervalued functionings or capabilities, is to be able to make that kind of decision over one's own resources and one's own life.
Is there anything in healthcare in general that you think is overrated? Like maybe too much attention is put towards it, and it could probably just be like taken out or maybe downgraded.
Well, the easiest answer for me to say is that, we put so much focus on diagnosis and less on functioning. And that's pretty much been my life's work. So that's first and foremost. But one of the things I would say, you want something very specific. And we talk about diagnosis in the discharge process, for example. We put so much emphasis that we have to have a diagnosis to discharge, right? But it might not make sense in all instances. And I'm going to give you another example. So I have another kid who has been having episodes of syncope, right? Where she's passing out. And she's been having several episodes over the last few years. Minor, they've been minor. And we've, notified the pediatrician, and everything, so far has been okay. A few months ago, she had an episode, but this time it was accompanied by convulsions. And someone who's worked in disability space, it seemed a little bit different than seizure activity. It wasn't typical. So I took her to the ER, and she had been running a fever, and I suspected she had the flu. We didn't take her to the pediatrician. We just had her, hydrated and well rested, and kept her home from school. So there we go to the ER, and I mentioned exactly what I just told you, and they give her an influenza A test, which comes back positive. Not surprising. She's about several days into probably having the flu at that point and exhibiting those symptoms. So then we get admitted into the ER, and they run all these different tests, and we have the neurologist consult comes in, everything, and they're not able to diagnose her. And whether it's seizures or not seizures, is it syncope? There's a code, I guess, for brief episodes of syncope with some convulsions, So they basically don't put that in the chart. And at the time of discharge, they say, we're going to let her go home. I look at the forms, I look at the papers, and they said she was admitted for influenza A. Well, we did not take her to the ER because she had the flu. We took her to the ER because she had passed out. This was, I think, the 5th episode in a year. And now it seemed to be more serious because there was convulsions that accompanied with it, right? And so, but that was not on the discharge papers. And so, diagnostic based system, they got what they wanted. They got what they needed, a diagnosis. It just wasn't the one that needs attention. Right. And so and I didn't leave, believe me, I didn't leave that hospital without complaining, and we got those discharge papers changed. But what I needed is something that I could give to my daughter's school nurse, right? She'll be going back to school. And I knew the flu would, resolve itself in the next day or two. By the time it was Monday, get her back to school. But I needed something to give to the nurse and to her teachers to alert them that, hey, you need to watch out for my kid because she could pass out at any moment. And these are some of the things, the precautionary measures we need to put in place to perhaps prevent this, like staying hydrated, for example, right? And not moving from one position to another very quickly. But it was nowhere in the discharge papers. So I complained, and we got it changed, and I was able to consult with the school nurse and then the teachers as a result. But that's why I say we need to move, as another example of why we need to move to a functioning based system. We need something that makes a lot of sense, right? That's going to be able to understand that continuum of care, what a patient needs as they move from one healthcare setting into another. And in this case, the setting for my daughter is school, but it could have been an adult, right? What they would need for going back into the workplace, right? To be able to accommodate them, to be able to make sure that they're in the setting with the best possible care, whatever that might be.
I think that's a really great example to kind of close this up. Care. So, awesome. Where can people find you?
Well, living in St. Louis, but I'm on LinkedIn. Also, I have a professional Instagram account, so they can certainly find me there. You can find me on Instagram. You can find me on LinkedIn as well. I'm the department chair at Bradley University, so a simple search online, you can find me. But I do ask people if they're interested in becoming, by becoming participants in any of these kind of projects. We have ongoing projects and working groups, and we're actually looking for social workers, more social workers to get involved. So if you have experiences, you have something that you'd like to, something that I said perhaps that somehow triggered a memory, or whether it's good or bad as a social worker, I'd love to hear it, because I'm always looking for use cases and examples that I can use in training materials. In my capacity as the co-chair for the Functioning Disability Reference Group for the WHO, I always need great examples as well of what we're doing. So I encourage everyone out there to please reach out and contact me.
Awesome. Okay. Thank you for talking today, and thanks for your leadership.
Thank you for having me, Christina. This has been amazing. You're such an amazing person, and the podcast has been so helpful for me too. So I appreciate being here.
Full circle moment. You're on it. All right. Take care.
All right. Thank you.